Today we are covering odontogenic fibroma, both peripheral and central types. This is a rare benign tumor, but examiners love it because it looks simple and is often misdiagnosed. So understand the logic once and you won't confuse again. Now coming why this matters. This lesion is commonly confused with peripheral fibroma, ameloblastoma, and even CEOT. The confusion happens because clinically it looks harmless, but histology tells a different story. Another exam reason: peripheral and central form behave differently, and management changes based on location. Key examiner focus: epithelial islands and calcification. If you miss these, you lose the diagnosis. Now coming on the definition or overview. Odontogenic fibroma is a benign tumor derived from odontogenic connective tissue. What makes it odontogenic is the presence of scattered odontogenic epithelial island, or sometimes with calcification. Peripheral lesions occur in gingival soft tissue, while central lesions are inside bone. Important Sorry for that. A important exam point is peripheral is relatively common, while central is rare. Now looking at the etiology and the causes. This tumor basically originates from dental lamina, remnants, or gingival epithelium. The key biological idea here is recapitulation of early odontogenesis. That means the tumor mimics early dental lamina behavior, epithelial islands interacting with the connective tissue. Peripheral lesions are extraosseous, while the WHO recognized central type as intraosseous. Now, the examiner hint is if you see recapitulation of the dental lamina, think of odontogenic fibroma. Pathophysiology. Let's break down this into steps. First, epithelial rest become active and form odontogenic epithelial islands. Second, the surrounding connective tissue proliferates, sometimes dense, sometimes myxomatous. Third, calcification may develop around these epithelial strands. Clinically, peripheral lesions push gingival tissue, while central lesions slowly expand bone. This explains why the lesion is benign but locally noticeable. Now, let's talk about the clinical features. Peripheral odontogenic fibroma first. It appears as a firm, raised gingival growth. Color is usually normal, but ulceration makes it erythematous. Now, interdental lesions may separate teeth, which is an important clinical clue. Okay, separation of teeth can be seen here. Now coming to the central odontogenic fibroma, it is usually asymptomatic, painless, jaw swelling, slow growing, often detected incidentally on radiographs. Clinical pearl I have to tell you guys is any firm gingival growth that does not behave like simple fibroma deserves an histology. Now, coming on the diagnosis or key findings. Radiology. Peripheral lesions usually show no bone involvement. If calcifications are present, small radio-opaque flakes may appear. Central lesions show a well-circumscribed unilocular or multilocular radiolucency. Sometimes you will see cortical saucerization or faint calcification. Now coming on to the histology of this lesion. Fibrous connective tissue with odontogenic epithelial strands can be seen. Epithelial strands resemble dental lamina and may contain clear cells. Calcification may be present. This combination is diagnostic. Coming to the management or treatment of this lesion. For peripheral lesions, local excision is the treatment of choice. I repeat, local excision. But here's the catch. Superficial removal leads to recurrence. The excision must extend into deep connective tissue or the PDL, the periodontal ligament. For central lesions, Curettage or enucleation is sufficient. These lesions usually separate easily from the bone. Long-term follow-up is advised, although recurrence is rare. Now, before moving to the clinical scenario, most common mistakes